This is Dr. Narendrakumar from Chennai. I will be demonstrating an interesting case of endoscopic Draf 3 Lothrop posture. My sincere thanks to Dr. Chandramouli and Dr. Vivek for their support and guidance. A 65-year-old male presented with a proptotic eye on right side. This revision case of inverted papilloma operated a decade before. So these are the scans. The mass was very huge, engulfing the frontal sinus completely. So under general anesthesia, you can see a mass which is literally protruding outside the nasal cavity. The interesting thing is we planned and executed this case completely an endoscopic procedure. Draf 3 was planned. The initial step is to debulk the tumor, and that is done by using the lux forceps. For the fast decompressing the tumor is done using a microdebrider. So we started the steps concentrating more on debulking the tumor. These few steps are being forwarded little for the time consignment. You can see most of the polyps in the nasal cavity has been debrided away. So the initial steps will be the complete uncinectomy, which is already done in this case also. So superior attachment at the posterior lacrimal gland, all those places have been cleared. Microdebrider is a fantastic tool. You can see this, the old middle meatal antrostomy window. These are the bone has been debrided. The tumor surgery is most pathology that involves the skull base anterior to the anterior ethmoidal artery will necessitate a broad exposure of the frontal sinus. And moreover, the post-operative surveillance of the sinus cavity is also facilitated by the expanded frontal opening. And we are doing up opening the sphenoid sinus. This full house face. So ground lamella is opened. Shower curtain is done. Posterior ethmorectomy is complete. The two various types of Draf 3 is inside out method and outside in. The main difference between is in inside out, we widen the frontal recess via drilling from inside the frontal recess, moving in anteromedial direction. The goal is to remove the frontal sinus floor and bony septum with eventual removal of the frontal beak, and remove the frontal process of maxilla until the periosteum is exposed. Posterior extent of drilling is to first olfactory fiber. Whereas in outside in Draf 3 is begin by drilling the frontal beak with progression towards the frontal sinus and intrasinus septum posteriorly. Here the goal is similar to the inside out Draf 3 procedure with plan to remove the frontal beak, frontal sinus floor and bony septum. The only thing is only in reverse order. Expanded laterally to include the frontal recesses. And usually the mucosal flap placement over the exposed posterior bone has been done. This is the difference between Draf 3 types, inside out and outside in. Here we are opening up the frontal recess. We are debriding and removing the maximum amount of tumor present in the frontal recess. So we are clearing the tumor slowly. While debriding, we should be very cautious. Certain unavoidable situations can happen, and here we made an injury to the anterior ethmoidal artery. You can see, but this is nothing to worry. No scary. Just observe your bleeding point is over the anterior ethmoidal artery. It can be managed simply by bipolar cautery. This is more than enough. The cautery is make sure that you completely cauterize and the artery is dissected for the further clearance posteriorly. So we cauterize it completely and dissected the artery out. So this is a very simple one. So after that, posteriorly to that, the mass is there, which is also started debriding the mass. For the endoscopic Draf 3, the limits are well recognized. Laterally, it should be the periosteum of the skin over the frontal process of maxilla on both the sides. Posteriorly, the first olfactory facial fascicle on each side demarcates the project on the projection of the cribriform plate or the olfactory groove. Anteriorly, the anterior table of the frontal sinus is the limit to which the drilling should occur, maximized to the sinusotomy. So go by with the anatomical landmarks. We are doing the traditional Draf 3 in this case. To middle meatal antrostomy, you can see the posterior ethmoidal artery, which is intact, splenoidectomy, which is wired, removing the maximum tumor. And we decided now we will be proceeding for the Draf 3. You can see the frontal sinus, still the tumor is there, and we can't able to remove those with this amount of exposure. So the supro-anterior, the incision begins at the point of underneath the frontal sinus at the line in which the outer cortical rim of the frontal table. Laterally, the incision is placed in line with the median orbital wall. This will ensure that the full length of the ethmoid is included in the exposure. In general, the anterior and inferior limit of the medial of the septal incision is 5 mm anterior to the lateral incision. Just elevate this flap using your instrument, Rosen instrument, and you can do the same on the opposite side and debride this flap. You can debride it. Small defect is seen there. And now we enter into the drilling thing. The drilling is begun by removing the midline crust of the septal bone that remains underneath the frontal sinus. The bone removal then proceeds to the lateral wall where the periosteum is identified superiorly. The periosteum is often distinguished as a white barrier compared to the ulnar bone. This is performed bilateral on both the sides. The full limits of the future sinusotomy are now defined, with the periosteum marking the lateral limit and the olfactory fascicle defining the posterior limit. You can see the mass which is dissected slowly, and it is not possible to enter the skull base unintentionally unless the drilling occurs or near the first olfactory neuron. The interesting fact is the surgeons who are unfamiliar with this technique may feel little uneasy drilling in this block of bone because the dissection does not follow the usual sinus demertization usually done for the sinus surgeries. The bone is drilled in a single horseshoe movement between those anatomical structures, wironic to the maximum. The cavity is intentionally kept smooth to allow for easy drilling, fast removal. The posterior septectomy is done. This can be usually with Harrison punch also to go to the opposite side. Image guidance can give little more help, but we didn't use in this case. You can see the huge mass is present on the opposite side of the frontal sinus. This is also debrider. Any remaining frontal recess partitions is also removed. The intersinus septum is also should be removed. The orbital wall is followed to discover the orbital roof and this square of the cavity. Under careful visualization, the bone of the posterior septum is drilled back to the original first olfactory neuron. This T segment of the bone is very important to remove. This can be little faster if you use a Harrison punch. You can see the mass which is present on the opposite side of the frontal sinus. This is little hard and fibrous, so the maximum exposure is needed for the better removal. Just palpating it. The whole surgery is done without any navigation. You can see drill should be maximum covering the anatomical landmarks, and the dissection should be there, and this is the exposure. The lateral limit alone is expanded a little because most of the mass is present way back in the right lateral aspect of the frontal sinus. So make sure the bone is also covered with mucosal flaps or elastic sheets for the better post-operative care. This is the lateral most aspect of the mass, which is beautifully removed. Look at that. This can be achieved only by the Draf 3. There was no external incision has been done. Till now we were using a 0-degree endoscope, not changed. So the complete bone work, dissections, everything is done with a 0-degree endoscope. So this is a mass which is present inside the left frontal sinus, occupying completely. So which is also debrided out. The aim is to give the maximum removal of the tumor. Using the Draf forceps, we can easily remove the mass along with the attachment. So this is how we are debriding the mass, chasing the mass, the extension of the mass, the attachment of the mass. Just chase it. So make sure your exposure should be maximum, and your exposure depends upon the extent of the mass. So far lateral aspect is also removed easily. This is done with a small angled endoscope to ensure the complete removal. This angled endoscope shows the far extreme lateral aspect of the mass attached in the right frontal sinus, which is also has to be removed in this case. We were in the plan whether external incision is needed or not, but the wide exposure of the bone in endoscopic Draf 3 is more than enough in this case to give a maximum removal. You can see even the debrider is reached far lateral, but the mass is very fibrous and huge. The removal of this mass makes very time consuming, but without any external marking, we have removed it. Along with some angled endoscope, you can see the mass is removed. What we saw before, where far lateral compartment is also removed. The last bit of the mass is now removed and debrided. You can see the extreme thing. It's literally a teamwork. We completed the surgery with a good results. Post-operatively, the patient had a very nice improvement of the proptosis. Now with an angled endoscope, you can see the complete removal of the mass. Complete removal. And there is no dehiscence of any bone there. So this is a final picture of the mass removed completely. The Draf 3 is completed. With the good exposures, and this will make sure that our post-operative care also will be very easy and fine to further proceed. This completes a satisfactory endoscopic Draf 3 procedure, Lothrop, for inverted papilloma, recurrent mass. So this just giving the wash and placing a elastic sheet which completes the surgery. Thank you one and all for watching this video. Thank you all.